see. Okay.
Okay.
Right.
Hi, everyone. My name is Pelumi. I'm Adedayo. I am a board-certified obstetrician and gynecologist, and I practice in Georgia, about an hour outside of Atlanta. So today I'm going to be discussing about women's health, what you should be talking to your provider about, the questions you should be asking, what's important. And then when I'm done speaking, I'm going to turn over the conversation to Dr. Boateng, who's a urologist in New Jersey, and he's going to talk about men's health because I don't know anything about men. My first part obviously is geared towards women, but I think it's important for men to pay attention as well, because sometimes you as men can be the ones that catch something abnormal with your partners or your sisters, your mom, whichever women you have in your lives. So for example, I had a patient who was recently diagnosed with thyroid cancer because her husband noticed that her like the shape of her neck was a little different. She came in and she had cancer. So you can still be your sister's keeper and learn some stuff. Okay, everyone can see my screen?
Yeah, we can.
Awesome. So the way I am going to frame this discussion is kind of, imagine that a woman walked into my office and was like, "Here, I'm here for my my annual visit or my well woman exam or my preventative care, whatever you call it," and just kind of the things that I think are important, things I talk about, the screening tests I recommend, and things like that. And like Nina said, if you have any questions, we'll address it at the end, or you can just type it in the chat if you're uncomfortable speaking up. Okay. All right. So the first time you go into a doctor's office, right, the first thing they do is take your vital signs, particularly your blood pressure and your weight. And your weight is used to measure your BMI. And the reason those two things are important is because we know that blood pressure and the BMI, those are independent risk factors for things like diabetes, for hypertension, for sleep apnea, and even for some cancers. And particularly for women, BMI can be an indication or can be a risk factor for infertility as well. So when you come into the office, if any of these are outside the range of normal, then we kind of talk about how we can fix that, the steps we can take to remedy those. So say you come in and, I'm concerned about your BMI, it's overweight or it's in the obese range, we can talk about diet, how to incorporate diet changes, exercise into your everyday life. Sometimes it's worthwhile seeing a nutritionist to kind of help you figure out how your diet works. Because a lot of times I've learned that, I've noticed that people are really bad judges of what like a good portion control is. And sometimes it's helpful to just talk with a dietitian on how to address that. And then the next thing that I would talk to you about is your family history, particularly if you have a strong family history of diabetes, of hypertension, of elevated cholesterol. And again, the reason is because if you have a family history then you personally have increased risk of having any of this disease processes. And we can again talk about ways to reduce your risk. And then specifically for women, right, I want to know if you have a strong family history for ovarian cancer, uterine cancer, or breast cancer. The reason is because if I identify that you have risk factors, then we can do genetic screening to see if you do carry the genes that put you at increased risk. There's a lot of things that we can do to reduce your risk. So as a specific example, every woman has a 1 in 8 risk of developing breast cancer throughout their lifetime. But if you carry some specific genetic defect, your risk goes from 1 in 8 to 80%. So it's a pretty big jump. And the things we can do before you get to your 40s and 50s to reduce your risk significantly. So it's important to know your family history from that standpoint. And so after family history, the next thing we talk about that is important to talk about is like your menstrual cycle. I want to know what the pattern is like, the length. Do you have heavy flow to the point that you're missing school because or missing work because of your periods? Do you have pain with sex, for example, pain with bowel movements? And the reason why those are important is because that can help me diagnose if you have pathology like fibroids, which is very common for Black women, right? Most people that have fibroids are Black women. Irregular periods can also let me know if you have endometriosis, for example, or can also be a sign of some form of infertility. So kind of teasing that out is important. And I typically tell women to just have an app where you can put your, where you can kind of track your periods. Because if you see a doctor every year, I have like this long data set to kind of see, are your periods regular or irregular, and is there something going on with that? And then as a natural flow from menstrual cycle is contraception, which that's a whole, that's a whole topic on itself. But the way I think about it, or the way I talk about it with patients is, are you trying to conceive or are you not trying to conceive? If you are not trying to conceive, then we can discuss different birth control options that suit your lifestyle, your goals, your expectations. And if you are trying to conceive, and then we talk about how long have you been trying, because there's a time frame that lets me know if there's a problem or, if you can just keep trying. So if you're less than 35, right, if you've tried for more than 1 year, then that counts as infertility, and we need to like figure out what's going on. If you're older than 35, that time frame is shorter. It's 6 months. So I don't want, if for my patients who are 36, 37, I don't want them going 9 months before we decide that there's an issue and we need to address it. So so that's that. And also if for women who are trying or even thinking about conceiving, I generally recommend starting a prenatal vitamin, because that contains iron and that contains folate. Iron is important because the average woman is iron deficient, because you bleed, most women bleed every month, so you lose a lot of your iron stores that way. And folate is important because we know that reduces your risk of having a baby with a spinal cord defect. People always ask if they should like get some fancy vitamin, and 9 times out of 10, the answer is no. Any over-the-counter prenatal vitamin is sufficient. There's some people that may need a little bit more supplementation. So for example, if you are on a vegan diet, I want you to pick up another type of vitamin, because sometimes you may lack some macrovitamins with a vegan diet. Or if you've had a child in the past with a spinal cord defect, then I want your folate to be a little bit more than the average woman. But generally speaking, an over-the-counter vitamin is fine. So after we talk about things that are pertinent to your menstrual health and your family planning, then the next thing that I discuss is screening tests. And the screening test depends on how often you should do them, depends also again back on your family history. So that's why it's important to have that conversation, and how often you've had an abnormal test. So for example, if this year you had your lipid screening or your cholesterol screening and it's normal, recommendations that you don't have to repeat it for another 3 to 5 years. But say yours was slightly abnormal, and you have a strong family history for hypertension, diabetes, or high cholesterol, you probably want to screen a little bit closer to that. And then sexually transmitted infection screening or STI screening, I recommend everyone should get screened every year. You'll be amazed how often I diagnose STIs on women who have no symptoms. It's a general misconception is that, if I have chlamydia or gonorrhea, I would have symptoms, which is generally untrue. Most people have no symptoms. So I think that's important. And also, if you have an untreated STI, that also affects your risk. It can increase your risk of infertility in the future. So it's something to address yearly. And then we talk about diabetes screening, just like the screening for cholesterol. How often you should get it done is based on your age, also on your risk factors. And obviously your physician can delineate that a little better based on your personal history. And then I also screen all women for anemia, which is like low iron, essentially. And the reason is because, like I mentioned before, because we have a period every month, most women have some form of iron deficiency anemia. And a lot of the times you don't have any specific symptoms that lets you know that you have low iron. People just say things like, I'm tired all the time, or, you know, I have leg weakness. Sometimes people have restless leg syndrome from that. Some people just have like non-specific headaches, and all of this can kind of fall under an anemia, which is easy to treat. So I recommend to have that screening done every year. And that's just a blood test for a complete blood count. So after we talk about the generalized screening, then I go into cancer screening, specifically cancers that affect women. The first one is cervical cancer. And the way we screen for cervical cancer is a pap test or pap smear. And cervical cancer is one of those cancers that is totally avoidable. As long as you get your screening pretty frequently, nobody should be getting cervical cancer in North America. The patients that I see with cervical cancer are like the 40 or 50-year-olds who haven't seen a gynecologist or a provider and haven't had a pap test in many years. But even if you have an abnormal pap, there are a lot of things we can do before it becomes a cervical cancer. So this is vital. And the way the screening is that for ages 21 to 30, you should get it done every 3 years, and 30 to 64, you should get it every 5 years. If you have any abnormal screening in that time frame, then the interval will be shorter. But this is like the general, I've never had an abnormal PAPS screening guidelines. And then the other screening, the other cancer screening that comes up is breast cancer screening. Given the demographic of this group, most of us probably don't need a PAP, don't need a mammogram, which is a screening tool for breast cancer up until the age of 40. If you do have a family history for breast cancer or a strong family history of breast cancer, then you might have to screen a little bit earlier. And so that goes back to knowing your family history, talking to your doctor about your family history, and seeing if you do qualify for early screening. I recommend all women should do periodic self-breast exams. So just in the shower, just feel your breast on, and the reason why that's important is because if you know the normal shape, the normal contour of your breast, if there's anything abnormal that comes up, you know something's up, and you can bring it up to your physicians. And the few times that I've diagnosed breast cancer in young women, because the risk is low in young women, but it's not zero. The few times that I've diagnosed breast cancer in women is because they're like, oh, something felt weird, and they came in, and then we caught it early. So it's always good to, I say, know your breast. And then the other thing that I talk about with my patients is mental health. And the way I screen that is, there's a couple of standardized ways to screen for depression. And I just ask the questions on the screening test. And the reason why I do that is because I've noticed that, especially with African Americans and Africans, our culturally, we don't easily come out and say, hey, I think I have depression. And a lot of times women will come and they're just talking to me about different things. And it's obvious to me that they have depression, but it's just not something that they have, they've grown up to be comfortable talking about it. So if you feel like your provider isn't addressing it, please bring it up. And if I diagnose someone with depression, or I'm concerned for depressive symptoms, a couple of ways I can get them plugged in to help. The first way is just referring them to a mental health provider, be it a psychologist or psychiatrist, based on what their needs are. I also tell, a lot of people don't know this, but if you work for a big company or you work for a big corporation, by law, they have to have something called an employee assistance program. And in that program, you have access to free mental health services. It's only about 3 to 5 sessions, depending on your company. And it's an independent provider. So if you seek help, it doesn't reflect back. Like, people at your job won't know that you're in therapy. Not that there's anything wrong with therapy, but sometimes people don't want, you don't want people at your job to know that about you. So that's also something to look into, because sometimes some insurance companies don't pay for therapy care, and this is kind of a good way to get your feet wet, find a provider that you like, and it's covered by your employer. And now there's also a lot of online portals or online companies that provide licensed mental health providers. So I know people that have used betterhelp.com, and they've had good experiences with it, and it's much cheaper than going the traditional route. So for example, BetterHelp charges you, I believe, $60 a month, and you have 4 sessions a month. So that's for anyone who's ever gone to therapy, that's significantly cheaper than having to go through your insurance company. So that's another option. I've heard there's also Talkspace. I don't know anyone who's used that personally, but that's kind of a way to get plugged into care. And so and that's all I have to say, and we can have questions afterwards. But the last thing that I want to add is that I understand that as Black people in general, we have a very tumultuous relationship with the healthcare system, because truthfully speaking, the healthcare system hasn't really been there for Black people for many years, right? And that's why most people don't go to the doctor. Most Black people don't go to the doctor until things are dire. And there's good reason for that, right? Everyone's heard of the Tuskegee experiment where they gave syphilis to Black people in Alabama. Even in gynecology, right? The person that we call the father of modern gynecology, he did surgery on Black women in Alabama without anesthesia. And he thinks that you thought that Black men didn't have the ability to feel pain. So there's a long history of why Black people shouldn't trust the healthcare system. But I think that we kind of need to get not over that, but we need to get past that and take charge of our health. And the way to do that is see a doctor or provider. It can be a nurse practitioner yearly to address any of these issues. If you feel like your doctor isn't listening to you, find a new provider. Ask questions, right? If you think you should be getting a screening test or you should be getting something done, don't feel afraid to ask your provider, hey, should I get this done? Why or why not? So that's all I had to say. And then we can open it up for questions.
Hi, Pelumi. Thank you so much for your expertise and taking the time out to share a little bit on your knowledge on well-being for women. We had a question for you from Ogechi. She mentioned, what's your definition of irregular cycle when it relates to infertility and fibroids?
So irregular cycle essentially means that you don't have a period, your period doesn't fall between 28 to 35 days, right? So, and that's why I mentioned that it's important to track your period. You write it in a book. It's probably easy to have an app. I use the app called Flow, FLO, and then you can see, from day 1 of your cycle, in the 1 month to the next cycle, what's the time interval, and anything that falls out of 28 to 35 days counts as irregular. Now, talking about infertility and fibroids, infertility by definition means that you've been trying to have a child. If you're less than 35, you've been trying to have a child for 1 year and it's not happened. If you're over 35, you've been trying for 6 months and it's not happened. And those things can intersect, and they may not intersect. You may have normal periods but have infertility for a million other reasons, right? You may have fibroids and not have infertility. You may have infertility and not have fibroids. So they have the kind of different parts of a Venn diagram. But that's why it's important to kind of talk to a provider and see what exactly the concerns are for you and work from there. I hope that answered your question.
Yeah, thank you so much, Pelumi. We're gonna give it up to Mr. Dr. Boateng to kind of present his side for the presentation, and for the people that have questions on the chat. After Dr. Boateng, we're gonna have a Q&A session, so you can ask Dr. Pelumi or Dr. Boateng more questions. Thank you, guys. Okay, Dr. Boateng, you go ahead.
Okay.
going to share my screen here. Okay. All right. Hello, everybody. My name is Akwasi Boateng. I'm a urologist based in New Jersey with a group called New Jersey Urology. I'm from Ghana. I was enjoying the women's talk. I mean, I was kind of hoping that it would just go on forever, but I have to represent for the guys. Can you all hear me? Okay.
Yes.
Okay.
Yeah, we can.
So just a little bit about me. I was born in Ghana, grew up in the Bronx. Went to school at upstate New York. Did my surgical training at Cincinnati and my urology at Cincinnati. And now I'm in Jersey. Dorian asked me to do this talk and talk a little bit about men's health. When he first brought this up, I was trying to figure out what the hell does men's health have to do with African Business Club. But when you start looking deep into it, health is probably one of the most important things. You have to be alive to be able to take care of your family, to be able to generate the wealth that you need to. So I was trying to figure out what to talk about, and men's health is a vast field. One of the advantages for the women is a doctor like Pelumi can provide a breadth of care for the women. She can talk about mental health. She can talk about just primary care matters, just general screening of blood pressure and all these things. And a lot of women will have their obstetricians and gynecologists as their primary care doctor. For guys, we don't really have someone who kind of consolidates our care. Yes, everyone needs a primary care doctor, but when it comes to men's health, it's sort of fragmented. So we're a little bit disadvantaged, for that reason. I'll move on to the next slide here. So, I wanted to keep a theme of numbers, and I know that this is a group where we're all excited about finances and money. So I wanted to keep a theme about numbers, and so there'll be a lot of numbers that I'll talk about today. Pardon me if you're not very good with numbers. So the first thing I just want to mention, and I'm not going to go too detailed into this. This is something that is dealt with by the primary care doctors. For the women, it could be your primary or it could be your gynecologist. So you can take a screenshot of this. These are sort of the normal numbers for blood pressure, your BMI, body mass index, which looks at obesity. But a couple of things I want to point out. 1/3 of men have high blood pressure. So we have 44 people in this participating in this talk. So 1 out of 3 men in this group right now probably have high blood pressure. That's a huge number, right? And then let's look at obesity. Again, another 1 out of 3 men will be obese. And why are these important? Pelumi mentioned a little bit about it, but all these things put us at risk of basically of dying. Dying from various things, whether it is stroke, whether it is heart disease. The other couple of things that I want to mention, cholesterol. You need to know what the cholesterol numbers are when you go to see your primary care doctor. Just look at these numbers, take a screenshot, and just ask them. What is my cholesterol? What is my good cholesterol? What is my bad cholesterol? And just try to keep track of that.
Those are things that can be fixed relatively easily with some diet changes and also activity. How much activity should you have? You should, 150 minutes per week of mild physical activity, which is kind of like a brisk walk. You don't have to play basketball to stay healthy. You can just move. And sleep. Sleep is, I can't begin to, I didn't know that there were so many studies linking sleep to so many health problems. It's incredible. I mean, I discovered a lot of them just researching for this talk. But yeah, you try to get your 8 hours of sleep. We've all learned this from elementary school and so on. And then I just wanted to introduce the guys to, the top 3, what we call visceral cancers or non-cutaneous, cancers outside of skin cancer. The top 3 cancers of the body are prostate, lung, and colorectal, right? For lung and colorectal, the biggest risk factors tend to be smoking and family history. Prostate it's a large number of men with prostate cancer, and I want to focus my talk on prostate cancer, and screening for prostate cancer and who should be screened. That's what the majority of my talk is going to be today. All right. So before I get into it, 2 questions that I always get whenever my profession comes up is number 1, what is a urologist? And then number 2, what is a prostate and what does it do? I wish I could take a poll to see how many people can actually answer these two questions. Do I have any volunteers? All right. So a urologist is urology is a subspecialty of surgery. So we're surgeons, by trade. We operate. We take care of organs of the urinary tract. So you start from the top. You have the kidneys. You have the ureters, or the tubes that basically, drain the kidneys of urine. The urine goes down into the bladder. So we also take care of the bladder. We do surgeries on the bladder. You think about the path of urine. Urine passes out through the urethra or the P channel. So we take care of that whole system. The prostate happens to be both part of both a urinary organ and a sexual organ. All right, so it is part of the channel that brings the urine out of your body once it leaves the bladder, and it's also a sex organ. So with the process of ejaculation, the sperm eventually makes its way out through the body, right? And before it gets into the P channel, it has to pass through the prostate. And the prostate makes a bunch of chemicals to help protect the sperm, because we're told that the female system is very hostile for sperm. So it needs some protection. So the prostate does that. So it's good for some things. Unfortunately, when it's done with what it's meant to do in terms of reproduction, it just starts to cause problems. And we'll talk a little bit about that, all right? So men's health, again, broad field. There's no way I can get into it, get into every single detail here. The things in red are the things that urologists help to manage, right? So it starts from primary care. We have things here like mental health, we have fitness, there's diet, and fertility, things like testosterone, erections, ejaculation problems, sex relationships, sexually transmitted, infections. So everything in red, the urologist can help to manage, all right, typically. I'll focus on prostate. I'll focus on prostate health, the first topic there. So just want to talk a little bit about why I want to focus on prostate health. Everybody hears about the prostate cancer. We hear about it all the time. Basically, 1 in 6 men will end up having prostate cancer. That's huge. 1 in 6 men. One of the reasons why I went into urology, my uncle actually died of prostate cancer. And, at that time, I was young. I didn't really know what it was. All we knew was, he was having trouble peeing and this and that. And, witches and wizards. And then the next thing you know, he's dead. Right. So it's later on that when you come back and you look at all these things and you think, he definitely died of prostate cancer for what was going on with him. There are 34 million men living in the United States with prostate cancer right now, as we speak. 34 million men. How many people are there in the United States? I mean, there are like what, 300 and something million, right? I mean, that's incredible. This year alone, there will be, almost 200,000 men diagnosed with prostate cancer. It's the second leading cause of cancer-related deaths. There'll be about 35,000 men that will die of prostate cancer this year. And the focus of my talk really is today is, it's important because Blacks, African Americans, Africans, Caribbean, wherever you are, Blacks just have the highest incidence and the highest mortality rates of all races. So it's important for us to know about it, to learn about it, to tackle it head on, and to know when to start, getting screened, because screening does save lives. Screening means we typically will catch the disease early. And when you catch it early, we have many cures, and cure rates are actually very high. When you catch it early, we're talking 80+% rates. 98% of men diagnosed with prostate cancer will be over 50 years of age. So it tends to happen to, middle-aged men and older. The youngest age I ever saw was somewhere around, I think it was like 36, 37 years. It was a Hispanic guy. So, one of the questions is, well, if it's a condition that happens to 50-year-olds or 60-year-olds, the average age is actually like 67, 68. Why should we learn about it now? I think I saw one of the demographics that some of the moderators had put up a couple of weeks ago, that the age range in this group is somewhere between low 20, mid 20s to about early 40s. So let's put this in perspective. Why it's important. A little bit about numbers, okay? So let's say you're 40 years old. And you have a second-degree relative, say a cousin who has prostate cancer. All of a sudden, your risk of having prostate cancer is almost double, right? So all of a sudden, just because you have a cousin that had prostate cancer, your risk is double. Now, let's say you had a father, your dad had prostate cancer. Your risk goes up to 2.2%, 2.2 times the average risk. So number one, Blacks, we have the highest incidence. Number two, if we have a family history, then it's even higher, right? If you have a a first-degree relative, a father who was diagnosed before the age of 65, your risk is more than 3 times. All right. If you have a brother, your risk is again more than 3 times. And if you have two people in your family, 2 first-degree relatives, your risk is more than 5 times. Somewhere close to 7 times. So all of a sudden, you start to see why this can be important, because it's not just the fact that we are at risk. It's like we are at double the risk, triple the risk. So let's talk about who should be screened for prostate cancer. Who, what age range? The American Urologic Association recommends that a man between the ages of 55 to 69 should be screened. And actually, usually the primary care doctors can do the screening as well. It's not very difficult to do. You really just have to bring it up, and then they'll just talk to you about it. We'll go into details a little bit. A lot of the other associations also support this recommendation. So when you move down, so what about the men, 40 to 54 years, less than 55? That's where most of the people, I imagine most of the people in this group will probably fall in that category. The recommendation is that it has to be a personalized decision between you and your doctor, you and your primary care, you and your urologist, etc. The recommendation, I don't think I put it on here, but the American Urologic Association recommends that if you don't fall in that optimal age range, 55 to 69, but you have a significant family history, you should get screened, at least 10 years prior. So all of us, all the Black guys in this chat should be looking to get screened, not at 55 years old, but somewhere between 40 to 45, right? Because we are all in a high risk category. If you're over 70, typically we try not to screen, but if you're in good or excellent health, you can be screened. And if you're younger than 40, it's typically not recommended that you get screened. Some folks have advocated that you can still get like a baseline screen. Maybe you're 38, you can get a baseline screen, and then once you hit that 45, we can kind of compare all the stuff that we did back then, all the numbers. So let's talk about what the screening entails. Now, I know there are probably a lot of guys in this group, and if they're anything like me, I forget things very easily. So I try to keep it simple. So it's just 2 3-letter words that you have to remember. Right? That's all the screening is. 2 3-letter words. The first one is a digital rectal exam, or DRE. Right? You get in there, your primary doctor or the urologist will, with a finger, it's called a digital rectal exam because we use our finger. We use a finger to basically, through the rectum, palpate or feel the prostate for any lumps and bumps. The prostate, should feel like, basically like the palm of your hand. If you feel a knuckle, that's usually problematic, and that is associated with high risk of prostate cancer. A lot of guys try to get out of this because what guy wants to go in and get a prostate exam, right? But it's a, I don't know, 3-second, 5-second test that can save your life. The second thing is something called a PSA, prostate specific antigen. That's the other 3-letter word. So every guy needs to know these 2 3-letter words, DRE and PSA. If you go in and your primary doctor only checks a PSA, you ask him, what about a DRE? If they only do a DRE, you ask them, what about a PSA? So PSA is a prostate specific antigen. As the name says, it is a protein that is only made by the prostate. And we can test it in the blood. So, with your annual blood work, they can just add it on, and basically you want the PSA. The numbers changes with age, but in general, you want your PSA to be somewhere around 3 to 4 or less. 3, 4 or less. If it's 5, 6, 7, then we need to ask more questions. The other thing about the PSA is, we check it every year so we can track how it changes. If one year it is 2 and the next year it is 3, well, it might be concerning. Or even if one year it is 0.5 and the next year it is 2, that's a huge jump. That's, more than a triple increase. So we need to ask questions. So, I just, not to, kind of belabor the point, I just want to, this is basically what I want to introduce all the participants about today. I will open things up for questions. I want to end with a quote here by Joan Welsh, a congresswoman back in the 80s, who says, "A man's health can be judged by which he takes 2 at a time, either pills or stairs." So, your health, you have to take your health seriously. Otherwise, you end up taking pills at the end of your life, and doing things like exercising and small things can really make a difference. All right. I know Dorian asked me to come up with a common sense finance tip. I know nothing about finance. That's probably why I joined this group in the first place. But I can give a common sense health tip, especially to the guys, which is, you wouldn't get into a football game without a quarterback, right? You need a quarterback. The primary care doctor is going to be your quarterback. He or she is going to be the person that's going to, look after you and get everybody involved, every specialty involved that you need. If they feel like you need a urologist, they'll send you to a urologist. If they feel like you need a heart doctor, they'll send you to a heart doctor. They'll do all those basic tests. So, the common sense health tip is that every guy needs to find themselves a primary care doctor, and not just not just any primary care doctor. Preferably, you want to find one. You want to find a minority primary care doctor, because studies have shown time and time again that minority patients do better with minority primary care doctors. I can even look at the urology world. When we look at the urology world, I mentioned that prostate cancer is more prevalent and more deadly in African American men. But even if you correct for all the variables, right? If you take a white person and a black person, and you correct for all the variables, they're in the same neighborhood, they have the same medical problems, they're equally as rich or equally as poor, they have the same access to healthcare. If you compare those two groups, the black person will still do poorly, by about 1.2 to 1.3 times. They will have an increased risk of having cancer come back, and they'll have an increased risk of death. So a lot of things that we still don't understand, but we know that having a doctor that looks like you, helps to bridge some of that gap. All right, so I'll end there, get a primary care doctor, and I'll open it up for questions. Here are a few resources here. I want you guys to check out Urology Care Foundation. This is a non-for-profit, basically free to the public organization. They do a lot of different things, but one of the things that they do that I like is they provide information, a breadth of information about everything men's health. So from mental health to stuff that I just talked about, You know, they have free brochures that you can print out, you know, PDF formats. They talk about prostate cancer, you know, testicular cancer, all the things that black men, young black men should be doing now and educating themselves about. So you know, I urge you all to check out Urology Care Foundation, which is very good. All right. So I'll take questions.
All right, thank you so much, Dr. Boateng. Really appreciate your expertise on this subject. Really appreciate it. We had a few questions for Dr. Adebayo, so I'm just going to read it right now. And also, if you have, for the people on the call, if you have a question, please feel free to use the raise your hand feature. And you know, when it's your turn, we'll unmute your mic so you can ask your question. I know we just have Adeleke raise his hand, so I'm just going to read a few questions that was asked to Dr. Adebayo earlier. So Pelumi, I'm not sure if you're on mute. Are you on mute, Pelumi? Can you hear me? Let me see if you're on mute, Pelumi.
Yeah, I'm unmuted now.
Okay, perfect. So we had a few questions. We had a question from somebody that using an iPhone. We also had a question for, like, I'm going to read both of them together, just kind of in this for a second time. Do you advise? Okay, go ahead.
I can see the questions.
Go ahead.
Let's see. Okay, so the first one was the one from iPhone says, "Hey doc, do you advise surgery for fibroid removal if the person still wants to have a baby? If the fibroid is destroying your physique, making it look like you're pregnant because of your tummy due to fibroid?" And the answer is like 100%, right? If a fibroid is affecting, even if you're not trying to get pregnant, if a fibroid is affecting the quality of your life, if you know it's big enough that makes it look like you're pregnant, you should have it removed. Chances that if you have a fibroid that big, your periods are probably heavy, irregular. If you're sexually active, you're probably having pain reflex too. So I would recommend taking it out. And you have to remember, right? Fibroid literally just means, or myomectomy means you're just taking out the fibroid, so you leave your uterus behind. Depending on where the fibroid is, you do have the risk of it affecting fertility in the future. But that's a conversation you have to have with your provider. Depends on where the fibroid is. But if it's affecting the quality of life, I 100% recommend a consultation and taking it out. And even if you don't want surgery, there are a couple of options that can take out a fibroid depending on their location. And then Falake asks, can you speak on the high maternal mortality rate, especially for Black women, and what you advise to reduce the rate? So that's a great question. And for those that don't know, right, the maternal and neonatal mortality in the United States is abysmal. Right? It's comparable if you think about third world countries. It's actually comparable to some third world countries, and in all industrialized nations, we have the worst maternity outcomes for Black women, and the discrepancy is anywhere from like 3 to 5 times. So a Black woman in America is 3 times as likely to die in childbirth compared to a white counterpart. And when this conversation first came up, a lot of it with the medical community thought it was because Black women don't go to see a doctor, Black women have increased hypertension, obesity, diabetes, etc. But when they controlled for that, so when they take out all those factors, Black women still are increased risk. So if you take me, for example, if you compare me to a white physician who makes the same as I do, who lives in the same community that I do, who has the same education that I do, I still have an increased risk of dying in childbirth. And that begs the question that if it's not with the patient, then where's the problem? And without a question, the problem is with the medical community, right? If people come into us and we're the factor that affects them before they die, then there's something wrong with the medical community. And a lot of that has to do with cultural bias, right? So people, for example, people still think that Black women are not, don't feel pain like white women do. So people don't take you seriously when you say, oh, my chest hurts. And they think you're just exaggerating, but that woman is probably having a blood clot to the lungs. So the things that we personally can do, like as an individual, is find a provider you're comfortable with. If you think the doctor isn't listening to you, switch practices. Like you can break up with your doctor. That's totally fine. If you feel like they're not addressing your concerns or validating your concerns, you can find a provider. I feel like culturally, we don't ask questions. Like, ask questions to your doctor and ask questions to your friends, right? Like, hey, if you know someone's been pregnant, like, I'm going through the symptoms. Did you have the symptoms? Like, what would, how did you address this? And then another thing is knowing your health and owning your health. So for example, if you know that your mom had preeclampsia when she had you, preeclampsia is a disease, it's a high blood pressure that women have in pregnancy. If your mom had preeclampsia, you actually have increased risk of having preeclampsia, and we can drastically reduce that risk in you by having you on the baby aspirin. So that's an easy fix that I can do after 12 weeks. But if you don't bring it up, or if you don't know that that family history, then we lose the opportunity to make the difference. So in general, just know your health well, ask questions. If you feel like someone isn't listening to you, get a new doctor. So when Narik asked about credible resources for vegan diets, I don't know much about diets. I always tell people I know a lot of things, but there's some things, that is not my strength. But if that's something that you're interested in, you probably want to meet with a dietitian or nutrition counselor to kind of work you through that. I will say though, generally people that are on vegan diets sometimes tend to lack some vitamins, so you need to take that into consideration. So things like vitamin A, the A, D, E, people, if you're not eating meat, a lot of times you're a little deficient in those. So if you're going to be a vegan, I typically tell you to be on some multivitamin supplement. Let's see. Someone asked me, what is your take on placenta encapsulation? So for people that don't know, that means that after you have your baby, there's it's not a new trend, but there's a trend to kind of dry out the placenta, grind it up, and put it into little tablets. And the reason why people do that is that, they report that it reduces your risk of postpartum depression, reduces your risk of anemia. But all of those reported benefits are just based on anecdotes, there's no research to back that up. It's almost no research to back it up. There's very limited data on it. So I personally am not a proponent of that. But I always tell people, whatever choices you make are your choices. You just have to understand the benefit versus the risk, and you think the benefit to you outweighs the risk. But generally speaking, there's no evidence to show that it improves any of those things. And also you have to remember the placenta is a raw organ. There's a chance that it has bacteria in it. So if you send your placenta somewhere for them to encapsulate it, like are they testing it for GBS or any of the bacteria in the vagina? And the process at which a lot of places encapsulate encapsulate the placenta doesn't get rid of those pathogens. So you're increasing your risk of infection that way. And if you're breastfeeding, you can pass that infection to your neonates. Sometimes the placenta actually over time collects heavy metal toxins as well. So you're, again, like taking that in high doses. So generally speaking, I'm not a proponent of that. If you have anemia, we can deal with that with iron supplements or increase iron in your diet. But yeah.
All right, thank you.
Those are all the questions for me.
Yes, we're gonna give it up to Adedayo, right? Adedayo has a question, so I'm just gonna have him unmute himself so he can ask his questions for Dr. Boateng. I'm not sure who that is.
Yeah. All right, thanks a lot for organizing this. I had two questions. The first one was for regarding the posture. So usually, like the older folks usually have the enlarged posture, right? So if you have an enlarged posture, does that necessarily mean you have posture cancer, or is your posture getting enlarged part of the aging process? That's the first question. The second question is, oh wait, that just skipped my mind. But I think that if you answer that, it will answer my second question as well.
Okay, sure.
Here, please.
Okay, all right. Thanks, Adeleke. To anyone in the group, you can feel free to send me a message, on Instagram. I'm not very versed on Instagram, but I will find a message and I'll definitely get back to you if you have any questions, outside of this topic. So enlarged prostate is, another one of those kind of 2-hour talks that I didn't even bring up. I try not to even mention it because, it is even more common than prostate cancer, way more common than prostate cancer. Something like 1 in 2.5 men will have that. It is something that basically happens. There's this term that has been coined called menopause. We always want to match the women, so we always want to get to whatever. So there's this term called menopause, which is kind of the equivalent of menopause in men. But basically around 45, 50-ish, there are some hormone changes that happen in our bodies that causes the prostate to grow. It has to do with testosterone and its metabolites, its breakdown products. And, this change in a man's body suddenly causes the prostate to grow. Many studies have been done, hundreds, that have shown no association between enlarged prostate and prostate cancer. So, how big your prostate is has nothing to do with whether or not you have prostate cancer. It's a diagnostic challenge for the doctor. Sometimes it's a little bit more difficult when you have enlarged prostate to make the diagnosis of prostate cancer, because some of the symptoms do overlap. But there's absolutely no correlation between the two. Okay.
All right. Thank you, Dr. Boateng. Again, if anybody on the call have any questions, please feel free to raise your hand or please type it in the chat box. I just have a question for you, Dr. Boateng. It goes in relate what you just mentioned, right? It says some men with enlarged prostate may refuse to take prescribed medication because of the side effects related to sexual function. What do you advise or recommend for those patients for medical adherence or other form of treatment?
Yeah, there's a treatment challenge that we have in urology. When it comes to management for enlarged prostate and also some side effects that it tend to have with sexual health. So, for instance, I mentioned at the beginning of my talk that the prostate is part of it's both a urinary organ and a sexual organ. And so by virtue of kind of where it's strategically located, it's almost like you can't really treat one without affecting the other, and that's kind of a tough thing, for us. So for instance, when you give a medication to help improve like symptoms of an enlarged prostate, a lot of times those medications will interfere with ejaculation somehow, whether it is the fluid that is coming out is going to be less because now you've kind of changed the dynamics. And so, yeah, a lot of folks will have trouble with compliance, will have trouble with being able to adhere to the medications because they will have some sexual side effects. We kind of hope that, and also not just with things, just general like ejaculation issues, but there can also be concerns with infertility. So for instance, if you're 50 and you're trying to have kids and you have an enlarged prostate, treatment for the enlarged prostate can also decrease your chances of having kids, because it can change the dynamics of how the semen the semen move through the body. So we kind of hope that by the time men start to have enlarged prostate issues, which is somewhere around 50 years, the majority of them would have hopefully have kids, but we run into those challenges. As far as what other treatments there are, you know, you have to speak with your doctor, but there aside from medications, you know, there are medications that relax the prostate. There are medications that will shrink the prostate. Those that shrink the prostate tend to have the least side effects sexually. And then there are procedures that can be done, you know, for instance, to kind of stent open the prostate and improve the flow of urination. There are many, you know, there are at least 10 different prostate operations that I can think of that have been developed over the years. Some, you know, have gone out of favor, but there are a lot of things that can be done. You know, it's almost impossible to kind of go through all of them here. But there are a lot of options. You just have to get in, you know, speak with your urologist and go through all the options.
Thank you so much, Dr. Boateng. Just one more question. We as Africans, we eat a lot of salt in our food, right? So I want to know, regarding high blood pressure, is there a correlation between salt intake and high blood pressure?
Yeah, I'll let Pelumi take this one.
Okay, Pelumi, I have to unmute you. Go ahead.
Yes, 100%, right? A lot of times for people that have high blood pressure or elevated blood pressure or stage 1 hypertension that they want to be on medication, the first line is putting you on what we call a low salt diet. And if you're consistent with it, you can actually reverse the changes of elevated blood pressure. If your blood pressure is, you know, it is like 140s over to 150s over 80s and 90s, diet alone may not make the change for you, but it definitely goes a long way. Does anyone have any other questions for us? Go ahead.
Someone asked about like a vegan diet. You know, I don't know too much about diets, but the Urology Care Foundation has a, you know, on their website, and it's not difficult to find at all. They have it's almost like they have a list of at least like 100 different food types, how to prepare them, ingredients for almost every kind of you know, diet category that you can think of. So there's a huge resource there that you can check out on the Urology Care Foundation website.
So anybody else on the call, you know, we still have Dr. Adedayo and Dr. Boateng here, you know. We just want to thank them again for, you know, gracing us with your time. Plus, please, if you guys have any more questions, please feel free to either, you know, raise your hand or please, you know, type it in the chat box. I think Ayo has a question. I'm just going to unmute him. Go ahead, Ayo.
Oh, can you guys hear me?
Yeah.
We can hear you.
Oh, okay. So this question is just to both of you, actually. As physicians, what do you guys do generally to stay in good health? I know the typical, you know, exercise and eat well, but are there anything special that you guys do? So for me, my story, I play soccer, so I'm quite active. I play soccer about 2 or 3 times a week. I eat quite healthy, and I try to do the normal things you hear people say, but I'm 38, about to be 40 in 2 years, and I told myself that I'm going to get myself a primary care physician, because I've never been to a hospital before, apart from going to have my kids or visiting people, right? And then upon going to the doctor, they told me that my blood pressure is off the roof. And I'm like, what the heck? You know, I eat well, I try to do the right things, but thankfully, I mean, they said it's reversible and, you know, they can catch it. But, you know, you guys being doctors, what do you guys think, you know, are the normal things that people should keep in mind, separately from obviously having that quarterback, like you said, Dr. Boateng?
Pelumi, do you want to take this one first?
Yeah, sure. I think that, so the most important thing is like eating right and exercising like you do. And sometimes if you if you have a family history of hypertension, for example, you're just based on your genetics, you're at increased risk for developing hypertension, no matter what you do. So you cannot change your genetics, but you can change your environment. So for example, with diet, like you have to look specifically, like even though you do eat healthy, like how much salt are you putting in your food, for example. And then for people who have increased risk of hypertension, sometimes it's helpful to be on a baby aspirin because that reduces your cardiovascular disease risk. And by cardiovascular disease, I mean like things like stroke, heart attack. That reduces your risk of that long term. So watching what you eat specifically, knowing your family history, and maybe being on a baby aspirin may be helpful.
For me, what do you do? What do you do? For me, I just try to listen to my wife. But you do have to see your primary care doctor, because no matter how well you think you are, there are some things that is just out of your control. Whenever we talk about primary care, we always talk about risk factors, and like Pelumi said, there are two types. There are modifiable risk factors, things that you can change. How much salt you put in your diet, how often you want to exercise every day, whether you want to eat at home or you want to eat out. And then there are some, fixed or non-modifiable risk factors, like who your father and your mother is, what race you are, which part of the country that you come from. Those things you can't change. And so if you have a significant family history of high blood pressure, there may not be, there are things that you can do to maybe prevent it from deteriorating, but it's possible that because of your risk factor, you may develop high blood pressure no matter what you do. And then the question is, how do you take care of that so it doesn't cause you complications? So it's not just a sort of a one-step process. It's you try to tackle it at multiple angles. Preventative. If you're diagnosed, then how do you treat it, and so on. For me, I pretty busy with work. I always say that I'm going to exercise. I don't. I probably just, I eat mostly at home. And I just kind of watch, things like cholesterol and sugar levels. Sugar levels are key for me. Like in my home, we've decided as a family that we're not going to drink soda, period. We don't drink soda. So, if we go out like to a party or something, maybe it'll happen, but at home, we don't buy any soda, because sometimes when you look at the nutrition, the nutritional value of these things, it can be scary just how much like teaspoon or tablespoon of sugar in a given 8-ounce can of Coke. When you pay close attention to those numbers, it's kind of mind-boggling. Other things like syrup, can have significant amounts of sugar that you have to be aware of. So, little things like, paying attention to what you're buying, can make a big difference. But again, you're not going to be able to, you're not going to be able to control everything, and so you have to leave it up to, some of the medical experts to help you, if there's something that is out of your control.
Yes, thank you so much, Dr. Boateng. So, Pelumi, just one more question for you on my side. Especially during difficult times like the pandemic, can you just talk about mental health, how people should deal with this? And, some people are having a hard time dealing with this pandemic. Some people love to, some people are actually missing, seeing their family, going to visit other places across the world. Some people are dealing with, those kind of mental issues, right? Can you just kind of talk a little bit on that?
Yeah, I think during the pandemic, I was telling my husband that I felt like I became a therapist as well as an OBGYN, because a lot of times, like, just talking about regular life, like patients just start crying in the office, you know, apart from just missing human connection. A lot of people lost their jobs and had a hard time with childcare. So it's a lot for everybody. I think that a couple of things that I tell people and that I do personally is have a support system, that you can tap into. If it could, you know, it could be your family members or your friends, a core group of people that you can talk to, and then you can cry and kind of share your stress with. Um, Another thing is I am a big proponent of everyone being in therapy, even before the pandemic hit. I think it's very important, given just like the stresses that we have as millennials, you know, all the constant stimulation that we get. It's helpful to have someone that you talk to um, on a regular basis to kind of help you almost, you know, to help you kind of sort out your feelings. So I'll give you my personal experience with therapy. Um, I started going to therapy in residency because if you know anything about obstetric residency or any surgical residency, it is literally the worst. And I felt like I just could not cope. And, you know, it was affecting my life. It was affecting my job. It was affecting my relationship. So I just made, and as a physician, as a Black woman, initially I felt, as a Christian, I felt like I don't really need to be talking to anybody about this. But it just got to a point where I couldn't carry the load by myself. You know, I didn't feel comfortable talking to anyone about it. So I went to therapy, and it was amazing. It's just sitting down in the office and talking to somebody. You know how they say like half of a solution is just sharing the problem. So I think that if you do have the resources, it's important to be in therapy, right? Just how we talk about taking care of your body, knowing your blood pressure, and all of that. It's important to take care of your mind as well, and that's why I put those options of if your insurance doesn't cover therapy, the different avenues that make it a little bit cheaper. BetterHelp. I use BetterHelp.com because now it's hard. Apart from the pandemic, it's just hard for me to make appointments during regular hours because I'm at my own clinic during regular hours. But talking to a therapist is online is actually helpful as well. And a lot of those companies match your therapist to your requirements. So, for example, if it's important for you to have a black therapist, you can put that on there, and they will match someone to suit you. And then and if you think that you don't really need therapy itself, that different things you can do, like meditation helps a lot. I use an app called Calm that I use in the mornings and sometimes at night, especially when I've had a stressful day in the OR and just to decompress. So there's a couple of things that I've personally used and I found helpful.
All right, thank you, Dr. Adebayo. So I think we're kind of coming close to the end of this meeting. So I'm not sure if anybody has, you know, any final questions or thoughts before I give it up to Doing to kind of close the meeting. So if you have any more questions, guys, on the line, please feel free to either type it or raise your hand. If not, I'm just going to hand it over to Doing to kind of wrap up this meeting. Okay, it doesn't look like we have anything else. Just from my side, Dr. Adebayo, Dr. Boateng, I just want to say we appreciate you for taking the time for you know, putting this together and, you know, presenting your expertise and some of the importance of taking care of our health. And with that said, I'm just going to hand it over to Doing to kind of close out our meeting.
Thank you, Wally. Thank you so much. Thank you, Dr. Adedayo and Dr. Boateng. Really appreciate the knowledge and the great information you guys shared with us today. It was very insightful. For our last segment, Dr. Boateng already gave me his part of it, but I'll ask Dr. Adedayo to give us a common sense. So usually it's a common sense finance tip, which is usually, you know, something that's common that everybody should be doing, but you know how they say common sense not so common. So we usually end that segment with our segments with a common sense finance tip. But Dr. Adedayo, it's up to you if you want to flip it to common sense health, like Dr. Boateng did, or just want to give us a common sense finance. Either one is fine.
Okay. I think for me, it's just ask questions. Like I'm a huge, like when patients come into the office and they're like, oh, I have these questions. I love it. Like if you just ask questions and I think in general, people sometimes feel a little hesitant to like ask their physicians questions. So that's why we're there. If something doesn't make sense, ask questions. You know, a lot of health portals these days, like patients who, after your appointment, if you don't remember something, get on the portal and shoot your doctor a message. I think that if you don't ask questions, you won't know, you know, and you don't know what you don't know until it's addressed. So that's it for me.
And write the questions down. You know, a lot of times you get into the doctor's office, you know, you talk about a whole bunch of stuff, and they say, you know, do you have any questions for me? And people just freeze, or they'll forget what they were going to say. But, you know, what I love is when patients come in with their questions written down and we just go through it, you know, and that's probably like the best way, you know, to save time and be more efficient. But that's a good point.
All right. Thank you so much, guys. We really appreciate it. And thanks to everyone for joining us today. We appreciate your time. Once again, this is African Business Club. Our goal is to normalize financial literacy, promote collaboration and sharing of ideas among Africans. And like Pamela mentioned earlier, and both of the doctors mentioned, we just want to kind of like, you know, switch up the topic a little bit away from finance, because like Dr. Boateng said, you know, you can't build wealth if you're not doing well, if you're not even alive. So that's why this topic is very important. And also, please, the conversation doesn't have to end here, so please join us. We have a session called Talk to Us Tuesday. It's every other Tuesday. The next one will be September 1st. So we dig deeper into our Sunday topics, so to keep the conversation going. And both of the presenters today, both Dr. Adedayo and Dr. Boateng, are actually both members of the African Business Club. So there's a good chance they will be there on Tuesday to answer more questions if you think of more questions, or if you just want to discuss a particular topic. And we also have a lot of healthcare professionals on as part of our members also. So it'll be a great if you can join us September 1st on Talk to Us Tuesday. And so also join us on Facebook, Instagram, African Business Club 2020. We have a lot of conversations going on, and just share the YouTube video will be out during the week. We'll share with everybody. So subscribe to our YouTube page, African Business Club. We have other videos there. If you want to check it out, if it's your first time joining us, you can take a look at those videos. Then lastly, I would like to just remind everybody, please vote. Elections coming up. I know this is not what we usually talk about, but you know, I know it's something we gotta all pay attention to. So let's take a look at our local communities and see what the rules are, and where, if you're not registered, please register. And lastly, let's remember we're all kings and queens, and let's treat each other as such. With that said, thanks again for joining us. Peace and love.